Though medical schools and residency training programs are actively recruiting medical students from underrepresented minorities, acceptance onto these programs is just the start. To talk about the challenges minority physicians face throughout their training and the structural changes that might be needed to address these, I'm joined by Frank Clark and Dr. Dionne Hart. Welcome. Appreciate that. Thank you. Let's kick off. So what is the experience of Black students in medical school today?
That's a very good question. I feel that we are still trying to overcome the obstacles that have been seen throughout our history as it relates to a lack of a diverse workforce. When we look at present day and we think about what are Black medical students, facing, we're still facing this uphill battle of trying to diversify our workforce. Dr. Hart and I, we make up 2% of the psychiatric workforce.
Right.
And as Black individuals, we make up 13% of the population. So there's quite the disparity there. And in order for us to improve the health outcomes of the communities that we serve, we need a diverse workforce.
What are some of the specific challenges that Black students face?
I think what Dr. Hart was saying about not having a lot of numbers of students there really comes into opportunities for residents and medical students to feel like they belong.
Right.
So if you're always in the world where you're a minority, you have this sense that you're other, that you don't belong. And, I think as a community, we do a really good job about teaching kids that education is an opportunity to move past where your parents were.
Right.
But we haven't done a good job of making people feel welcome in medicine. So we've been at the same numbers since like the 1960s as far as the number of minorities in general, only 9% in medicine. But at the same time, the number of Black men has been going down. And a lot of that is because people feel other and they don't get the support. So right now, Blacks are about 5% of residents, but 20% of those who are expelled. So there's not the same amount of support, and there's not a lot of sponsorship and mentorship within medicine so that we can at some point reach 13%.
What do you think the longer term impact is going to be?
Well, when we look at the data and you look at longevity, I as a Black male have the shortest lifespan. Black women have a shorter lifespan than white women. So when we're looking at long term, we are looking at premature mortality, premature death, if we don't improve the health outcomes of the Black community. Another example to illustrate that is the maternal mortality that we see among Black women, right? 3 times.
And I think it really goes back to the point where zip code is a bigger factor than genetics in your health outcomes. And if we just think about mental health, Dr. Clark mentioned just 2%. So if you think about zip codes, how many of those 2% are within an area where Black communities specifically can walk to a provider where they have access? So access is very important, but then not getting the right diagnosis. So many people are underdiagnosed with mood disorders, trauma disorders, but they're overdiagnosed with thought disorders. So they're not receiving the right diagnosis, which means you're not getting the right treatment. You're more likely to get your treatment in an emergency room involuntarily. You're more likely to get your treatment in a correctional facility, not be referred for psychotherapy, to get substance use treatment. I mean, there's just so many factors that we know of that play into the role of Blacks having lesser opportunities to not only have wellness and the optimal health, but like you said, premature death.
Strikes me, though, incredible to me that we're having this conversation in 2023, right? There's such inequality and inequity, and we're still having this conversation. Seems almost, so what do we do about it? So that's, I suppose, the big question here is what's to be done.
There's a new, it makes me uncomfortable to talk about it, but it's like co-conspirator, where people are like, move beyond just being an ally and co-conspirator. because conspirator sounds negative, like you're doing something wrong. But it is an idea of that I don't just say that I'm supportive, but I do something. You know, even when you're not around, even when there's like anonymity, that you do something. So the idea that we need to inspire other people who are not facing the same barriers to do something means a lot. And at this meeting, for the first time, there's a resident fellow and medical student track. So there's opportunities to discuss, like in the structural racism session that we're going to have. So there's more opportunities to talk about what are those barriers, and to do it in a safe space where you don't feel like if I speak up, my program's going to find out and there's going to be some backlash. Like, so I think these opportunities to talk about it, to feel safe and having those discussions and having real solutions, and not just like scenes on paper where people check boxes and they kind of pat themselves on the back and then nothing changed. I think we're really moving past the talk and walking.
Well, thank you both very much indeed for joining us today. Really appreciate it. It's been great to talk to you, so thank you.
Appreciate it.